Foundations of Maternal, Newborn, and Women's Health Nursing by Murray, McKinney, Holub, and Jones. 7th edition. Chapter 23. High-Risk Newborn. Complications associated with gestational age and development. Maternity nurses identify and begin care for the immediate needs of neonates with complications until nurses from the Nicu can assume care. NICU nurses often attend births when complications of the newborn are expected. Care of high-risk newborns. Nurses care for minor illness or conditions in the mother-baby unit or the normal newborn nursery, but more serious problems require intensive care in NICUs, specialized nurseries designed for that purpose. NICU admission rates across the United States range from 84% of infants born weighing less than 1,500 grams, 3 pounds 5 ounces, to 7.8% of infants born weighing 2,500 grams, 5 pounds 8 ounces, or more. Multidisciplinary approach. The care of infants with problems at birth often involves collaboration among many different professionals. In the hospital setting, such professionals may include nurses, nurse practitioners, physicians with different specialties, respiratory therapists, laboratory personnel, and pharmacists. Care from social workers, physical therapists, feeding specialists, occupational therapists, and infant development experts may begin during the hospital stay and continue after the infant is discharged. Nurses often coordinate this care and explain or clarify it for parents. Late preterm infants. Infants born between 34 and 07 and 36 and 67 weeks of gestation are called late preterm infants because they have many needs similar to those of preterm infants. They are more stable than preterm infants but are physiologically and metabolically immature and have higher mortality and morbidity rates than full-term infants. In 2005, the Association of Women's Health Obstetric and Neonatal Nurses, AHWAN, launched a multi-year late preterm infant initiative to develop evidence-based practice guidelines for care of the late preterm infant. Results of the study showed 46% of late preterm infants spent some time in a special care nursery. Hypothermia, hypoglycemia, feeding difficulties, hyperbilirubinemia, respiratory distress, and or a need for a septic workup occurred in half of the infants studied. Incidence and Etiology. Late preterm births comprised 8% of births in 2013. Contributing factors in late preterm birth include elective and medically indicated inductions and cesarean births, preterm labor, premature rupture of membranes, preeclampsia, multifetal pregnancies, obesity, assisted reproductive technology, advanced maternal age, and inaccurate estimate of gestational age before birth. Characteristics of late preterm infants. Because late preterm infants often look like full-term infants, they may not be recognized as being preterm. However, they are physiologically immature. They are at risk for respiratory disorders, problems with temperature maintenance, hypoglycemia, hyperbilirubinemia, feeding difficulties, acidosis, and infection, such as respiratory syncytial virus, RSV, because of their immaturity. They are also at risk for long-term neurodevelopmental disorders as well as cognitive and behavioral problems. They are more likely to be admitted to the NICU after birth and are at increased risk for rehospitalization after discharge. Therapeutic management. Therapeutic management varies according to the problems presented. Many interventions are similar to those for preterm infants discussed in this chapter. Nursing considerations. Assessment and care of common problems. Late preterm infants may receive care similar to that for full-term infants, but compared with full-term infants, these infants need closer monitoring for complications during the hospital stay. Nursing care is similar to that given to preterm infants in many aspects. Thermoregulation. Once stable, normal newborns usually have their temperature checked once every 8 to 12 hours. A late preterm infant may develop cold stress that is not noticed until signs appear or it is time for the next vital sign assessment. Therefore, nurses should be more vigilant in watching for thermal instability in these infants. The temperature, as well as other vital signs, should be checked every 3 to 4 hours for the first 24 hours and then every shift, depending on need and agency policy. Kangaroo Care, a method of providing skin-to-skin contact between infants and their parents, is often used to keep infants warm. A radiant warmer or an incubator also may be used if the infant cannot maintain normal temperature. Feedings. Late preterm infants may have immature suck and swallow reflexes, have shorter awake periods, and fall asleep during feedings before they have fed adequately. They may have difficulty with latch when breastfeeding. Their low tone and weak suck may decrease the amount of milk they obtain with each suck. They have an increased caloric need and should be fed every 2 to 3 hours. Feeding problems are common, and nurses should assess feeding sessions to ensure swallowing is occurring. Breastfeeding mothers need special help to see that infants are feeding well. Two key breastfeeding elements to be assessed and supported are protecting the mother's milk supply and ensuring the infant is adequately gaining weight. The football and cross cradle holds are helpful in positioning these infants at the breast. Urine and stool output are monitored as indications of adequate intake. Late preterm infants are at risk for hypoglycemia, and blood glucose measurements should be performed according to hospital protocol, especially during the first 24 hours. Because late preterm infants are at greater risk for breastfeeding-associated rehospitalization compared with term infants, lactation consultants should be involved in their care. An evaluation of breastfeeding should be documented at least twice daily. Discharge. Late preterm infants often can be discharged at the same time as full-term infants. They should not be discharged earlier than 48 hours after birth. Before discharge, nurses should ensure infants are feeding adequately and have had normal vital signs for at least 24 hours. Bilirubin levels should be assessed before discharge. Teaching should include the need for keeping the infant warm. The infant should be kept away from drafts and dressed with one more layer than an adult would wear. Late preterm infants are subject to overstimulation. This may occur when parents take the baby home to an environment of many different stimuli. The nurse should teach signs of overstimulation and how to minimize them. A car seat challenge should be conducted before discharge to ensure the infant can tolerate sitting in a car seat without bradycardia, apnea, or decreased oxygen saturation. Parents bring their own car seat for the test. Preterm and low birth weight infants should be observed in the car seat for 90 to 120 minutes or more if travel time to go home is longer. Parents should be taught signs of common complications such as jaundice or dehydration and what to do if they occur. Because some problems may not be noticeable at discharge, late preterm infants should have a follow-up visit with the healthcare provider 24 to 48 hours after discharge. Preterm infants. Preterm infants, also called premature infants, are born before the completion of 37 weeks gestation. The word preterm is sometimes confused with the term low birth weight, which refers to infants weighing 2,500 grams, 5 pounds 8 ounces, or less at birth and of any gestational age. Very low birth weight infants weigh 1,500 grams, 3 pounds 5 ounces, or less at birth. Extremely low birth weight infants weigh 1,000 grams, 2 pounds 3 ounces, or less at birth. Although most of these infants are preterm, others are full term and have failed to grow normally while in the uterus, a condition called fetal growth restriction or intrauterine growth restriction. Incidence and Etiology. Scope of problem. Advances in technology have resulted in infant survival at much lower birth weights than ever before. The preterm birth rate for 2013 declined for the 7th year in a row to 11.39% of births. Disorders related to short gestation and low birth weight are the second leading cause of infant mortality, surpassed only by those from congenital anomalies and chromosomal abnormalities. In terms of the suffering of infants and their parents, lost potential, and medical expense, preterm birth is extremely costly. Infant mortality and morbidity rates increase as gestational age decreases. Causes. The exact causes of preterm birth are not known, but all risk factors in pregnancy are potential causes. See maternal risk factors for preterm labor. Prevention. Prevention of preterm birth is best accomplished by provision of adequate prenatal care for every pregnant woman to identify and treat risk factors as early as possible. Teaching women signs of preterm labor will encourage them to seek care early, maximizing treatment outcomes. Characteristics of preterm infants. Characteristics of preterm infants vary depending on gestational age. For example, the appearance and problems of infants born at 34 weeks of gestation are different from those of infants born at 26 weeks of gestation. Some characteristics, however, are common to all preterm infants. Appearance. Preterm infants often appear frail and weak, and they have less developed flexor muscles and muscle tone compared with full-term infants. Their extremities are limp and offer little or no resistance when moved. Premature newborns typically lie in an extended position. The infant's head is large compared with the rest of the body. Preterm infants lack subcutaneous or white fat, which makes their thin skin appear red and translucent, with blood vessels being clearly visible. The nipples and areola may be barely perceptible, but vernix caseosa and lanugo may be abundant. Plantar creases are absent in infants younger than 32 weeks of gestation. The pinnae of the ears are flat and soft and contain little cartilage. They lack the rolled over appearance of the pinnae of a full-term infant. In the female infant, the clitoris and labia minora appear large and are not covered by the small, separated labia majora. The male infant may have undescended testes with a small, smooth scrotal sac. Behavior. The behavior of preterm infants varies depending on gestational age. It often differs from that of full-term infants because of the stress of having to adjust to extrauterine life before they are ready. Premature newborns may have poor development of flexion and little excess energy for maintaining muscle tone. They are easily exhausted by noise and routine activities. Their responses are varied, including lowered oxygenation levels and stress-related behavior changes. The cry may be feeble. Assessment and care of common problems. Because preterm infants are unfinished in their growth and development, they are prone to problems affecting all systems and body processes. Problems with respiration. Problems with the respiratory system are a major concern because preterm newborns have immature lungs but must go through the same processes as the full-term infant to begin breathing. The presence of surfactant in adequate amounts is of primary importance. Surfactant reduces surface tension in the alveoli and prevents their collapse with expiration. It allows the lungs to inflate with lower negative pressure, decreasing the work of breathing. Infants born before surfactant production is adequate develop respiratory distress syndrome, RDS. In addition, preterm infants have a poorly developed cough reflex and narrow respiratory passages, which increase the risk for respiratory difficulty. Assessment. The infant's respiratory status should be observed constantly. The lungs are assessed for adventitious breath sounds or areas of absent breath sounds. The nurse differentiates periodic breathing from apneic spells. Periodic breathing is the cessation of breathing for 5 to 10 seconds without other changes, followed by 10 to 15 seconds of rapid respirations. Changes in color or heart rate do not occur. Although periodic breathing sometimes occurs in term infants, preterm infants experience it more often. Apneic spells involve absence of breathing lasting more than 20 seconds or less if accompanied by cyanosis, pallor, bradycardia, or hypotonia. Apneic spells are common in preterm infants, increasing in incidence with lower gestational age. Apnea without an identified cause in a preterm infant is called idiopathic apnea or apnea of prematurity and generally improves as the infant matures. Episodes may occur along with periodic breathing, and the infant may require gentle tactile stimulation, bag and mask ventilation, medications, or assisted ventilation. Apnea should be investigated because it may be related to other conditions. The nurse observes the effort required for breathing and the location and severity of retractions. Retractions are particularly noticeable in preterm infants, whose weak chest wall is drawn in with each inspiration. The excessive compliance elasticity of the chest cage during retractions occurs because the bones of the chest wall are very pliable. This may interfere with full expansion of the lungs. Grunting may be an early sign of RDS. It closes the glottis and increases the pressure within the alveoli. This keeps the alveoli partially open during expiration and increases the amount of oxygen absorbed. Nursing interventions. Interventions focus on collaborating with other team members, such as the respiratory therapist, to manage technical equipment and facilitate removal of secretions. Working with respiratory equipment. An oxygen hood is often used for infants who can breathe independently but need extra oxygen. The hood is a plastic dome that fits over the infant's head or over the head and upper body. The infant breathes the higher level of oxygen within the hood, and the device does not interfere with access to the rest of the infant's body for care. Oxygen also may be given by nasal cannula to the infant who breathes well independently. After discharge, many preterm infants continue to receive oxygen by a nasal cannula at home. Oxygen should be warmed to maintain body temperature and humidified to prevent insensible water loss and drying of the delicate mucous membranes. Continuous positive airway pressure, CPAP, may be necessary to keep the alveoli open and improve expansion of the lungs. CPAP can be delivered via nasal prongs, a mask, or an endotracheal tube. The infant may need conventional mechanical ventilation when respiratory failure, severe apnea, bradycardia, or other conditions are present. High-frequency ventilation may be used to provide very fast respirations with less pressure and volume. This helps decrease lung injury from pressure, barotrauma, and volume, volutrauma. When oxygen is administered, the level of oxygen in the infant's blood should be monitored. Arterial blood may be drawn for testing oxygen levels. Pulse oximetry may also be used. This method is less invasive and provides continuous information about oxygen partial pressure, PO2, levels through sensors attached to the skin. Nurses and respiratory therapists titrate oxygen, depending on the pulse oximetry or arterial oxygen levels, according to facility policy. The nurse should observe the infant's increasing or decreasing dependence on breathing assistance and need for oxygen during activities such as handling, feeding, and linen changes. An increase in oxygen and or other respiratory support settings may be needed during care activities. Positioning the infant. The side-lying and prone positions facilitate drainage of respiratory secretions and regurgitated feedings. The prone and side-lying positions are not recommended for normal newborn infants because they are associated with an increased incidence of sudden infant death syndrome. In the preterm infant, however, the prone position increases oxygenation, enhances respiratory control, improves lung mechanics and volume, and reduces energy expenditure. The reason for prone positioning should be explained to parents. Supine positioning for sleep is begun as soon as the infant can tolerate it and before discharge so that the infant can become accustomed to sleeping on the back before going home. The supine position often can be used at approximately 32 weeks gestational age. Before discharge, parents should be taught the importance of supine positioning in preventing SIDS. It is important for nurses to model SIDS prevention by placing infants in the supine position as soon as infants are able and removing any soft, loose items from the bed because parents are more likely to mimic the conditions they saw in the hospital. Suctioning secretions. The weak or absent cough reflex and very small air passages make the preterm infant's airway susceptible to obstruction by mucus. The nurse checks suction equipment at the beginning of each shift to ensure that it is available and functioning properly at all times. The infant is suctioned only as necessary. Suction should be gentle to avoid traumatizing the delicate mucous membranes. Trauma could cause edema, decreasing the size of the air passages further and leading to more respiratory difficulty. Suctioning also provides an entry for organisms and decreases oxygenation. The procedure causes changes in heart rate, blood pressure, and cerebral blood flow. Suction should be applied for only 5 to 10 seconds at a time, and increased oxygen should be provided before and after each suction attempt. The mouth is suctioned before the nose because stimulation of the nares causes reflex inspiration that could cause aspiration of fluids in the infant's mouth. A rest period should be provided after suctioning. Maintaining hydration. Adequate hydration is essential to keep secretions thin so they can be removed by drainage or suction. If infants become dehydrated, secretions will become thick and viscous and could obstruct tiny air passages. Fluid intake should be increased, as ordered by the provider, if secretions seem to indicate even minimal dehydration. Problems with thermoregulation. Although heat loss can be a thermoregulation problem for full-term infants, it is even more significant in preterm infants. Their skin is thin, with blood vessels near the surface, and little subcutaneous white fat for insulation. As a result, heat loss is rapid. The preterm infant's shorter time in the uterus allows less brown fat to accumulate before birth, impairing the infant's ability to produce heat. Preterm infants have a larger head in proportion to body size compared with full-term infants. The preterm infant's extended extremities increase exposure to air and thus heat loss. Their body surface area in proportion to their body mass is larger than that of adults. The temperature control center of the brain of preterm infants is less mature and may be further impaired by asphyxia. These conditions all contribute to heat loss. Complications from heat loss are more likely to develop in preterm infants. They include hypoglycemia, respiratory problems, metabolic acidosis, pulmonary vasoconstriction, impaired surfactant production, and more respiratory difficulty. In addition, calories used for heat production are unavailable for growth and weight gain. Assessment. The infant's temperature is monitored continuously by a skin probe attached to the heat control mechanism of the radiant warmer or incubator. Common probe placement sites are the abdomen, flank, and axilla. The infant should not lie on the probe. Skin temperature is usually maintained at 36 to 36.5 degrees Celsius, 96.8 to 97.7 degrees Fahrenheit. The infant's skin temperature, as shown on the bed or monitor, should be recorded every 30 to 60 minutes initially and every 1 to 3 hours when the infant is stable. The axillary temperature should be compared with the heat control reading to ensure that the equipment is functioning properly. The axillary temperature for a preterm infant should remain between 36.3 and 36.9 degrees Celsius, 97.3 and 98.4 degrees Fahrenheit, slightly lower than the temperature for full-term infants. If the infant has accumulated brown fat, a normal axillary temperature when the monitor shows a decreased skin temperature may indicate the heat from brown fat in the axillary space is being used to maintain the infant's core temperature. Rectal temperatures should not be used in preterm neonates. Checking a core temperature is of little value in a neonate because it may not show a decrease until the infant has completely decompensated. Indications of inadequate thermoregulation include poor feeding or intolerance to feedings in an infant who previously had little difficulty, irritability, lethargy, poor muscle tone, cool skin temperature, and mottled skin. Hypoglycemia and respiratory distress may be the first signs that the infant's temperature is low. A decrease in weight gain or weight loss may occur over time. Because temperature instability may be an early sign of infection, the nurse should assess for other evidence that infection may be present. Critical to remember: signs of inadequate thermoregulation. Axillary temperature less than 36.3 or greater than 36.9 degrees Celsius, less than 97.3 or greater than 98.4 degrees Fahrenheit. Skin temperature less than 36 or greater than 36.5 degrees Celsius, less than 96.8 or greater than 97.7 degrees Fahrenheit. Poor feeding or feeding intolerance, irritability followed by lethargy, weak cry or suck, decreased muscle tone, cool skin temperature, mottled, pale, or acrocyanotic skin, signs of hypoglycemia, signs of respiratory difficulty, e.g. apnea, retractions, poor weight gain if chronic. Nursing interventions. Maintenance of heat in preterm infants involves the same basic nursing care principles as for the full-term infant. These principles, however, should be adapted to meet the needs of the preterm infant. Maintaining a neutral thermal environment. A neutral thermal environment, NTE, is especially important to prevent the need for increased oxygen to maintain the infant's body temperature. The temperature necessary to maintain the NTE varies according to gestational age. Charts are available that indicate the appropriate temperature setting to maintain an NTE according to the infant's size and maturity. The delivery room should be warm to decrease heat loss at birth. Immediately after birth, the infant is dried and placed on the mother's abdomen or a pre-warmed radiant warmer for care, and a hat is put on the infant's head. Before infants are dried, place those who are younger than 32 weeks of gestation, or up to 35 weeks if the baby is small for age or the environment is cool, in a polyethylene bag or wrap the covers around the body from the shoulders down. This prevents heat loss by evaporation during initial care and transfer to the Nicu and is used until the infant's condition is stabilized. It also decreases insensible water loss. The infant should be placed on a chemical thermal mattress, which can provide heat for up to an hour after activation. Because they produce heat less effectively and lose more heat than larger or older preterm infants, smaller, less mature infants need more warmth to maintain body heat. Radiant warmers or incubators are used until infants can maintain normal body temperature alone. Some devices convert from a radiant warmer to an incubator and back again to eliminate the need to move the infant from one device to another. Infants needing many procedures are usually placed under an open radiant warmer to make it easier to see them and work with equipment. However, air currents around an unclothed infant can cause heat loss by convection, despite the heat generated by the warmer. Doors near the warmer should be closed and traffic kept to a minimum to decrease convective heat loss. The infant should receive only warmed oxygen because thermal receptors in the face are very sensitive to cold. Cold oxygen could quickly lead to cold stress. Equipment and caregivers should not come between the infant and the heat source, preventing heat from reaching the infant. A transparent plastic blanket over the infant allows heat from the warmer to pass across the infant. The blanket decreases convective heat loss from exposure to drafts and insensible water loss while maintaining visibility of the infant's body. Incubators are used for infants who do not need to be under radiant warmers. They have double walls to minimize radiant heat loss to the cooler outer walls. Warmed air circulating inside the incubator provides heat. Humidity should be added to decrease evaporative heat loss and insensible water loss, especially in very preterm infants. Incubators should be placed away from air conditioning ducts or windows that may affect the incubator temperature. When infants are in incubators, the nurse should keep portholes and doors closed as much as possible. A significant amount of heat is lost each time the incubator is opened, and it takes time to build up the heat again. When removed from the incubator for procedures or holding, infants should be wrapped in heated blankets and a hat applied. Incubator doors should be closed while the infant is outside to retain the heat inside. Infants should be placed under a radiant warmer or on a surface padded with warm blankets for procedures that cannot be performed inside the incubator. A heat lamp provides an alternative source of heat. Although temperature loss is the most common concern, overheating also is a problem for preterm infants. Overheating may occur when heating devices such as radiant warmers are set too high or a skin probe comes loose. Overheating leads to an increase in the metabolic rate, with increased oxygen and glucose needs, and insensible water losses. Alarms to detect high or low temperatures should be turned on at all times. Although temperature regulation in preterm infants is usually provided in incubators until infants can maintain their own temperature, warmth is also provided when parents hold them. Adequate temperature is maintained in stable infants during KC. Weaning to an open crib. Preparation of infants for moving to an open crib should begin early. When stable, infants can be dressed in a shirt, diaper, and hat while in the incubator. Clothing conserves heat and helps infants adjust to a different temperature on the face than the rest of the body. Infants who weigh about 1,600 grams, 3 pounds 8 ounces, have a consistent weight gain for 5 days, have no medical complications, and are tolerating feedings, can begin gradual weaning from external heat. Each NICU has its own protocol for the weaning process. The incubator temperature is usually decreased gradually. It is raised if the infant's temperature falls below the normal range. If the temperature remains stable, the process can continue the next day. When the infant is ready for transfer to an open crib, double wrapping with warm blankets helps insulate body heat. Sleep sacks, sleepers made of blanket material and closed at the bottom, are often used when infants are dressed. The temperature is assessed at gradually increasing intervals until the infant's temperature is stable and then may be monitored on a routine schedule. A blanket is added for a low temperature, but if the temperature does not rise to normal, the infant is returned to the incubator. Nurses should observe infants carefully during the first few days after transfer to an open crib. Signs that may indicate inadequate thermoregulation include decreased weight gain, poor feeding, or increased requirement for oxygen. Problems with fluid and electrolyte balance. Preterm infants lose fluid very easily, and the loss increases with a degree of prematurity. The rapid respiratory rate and the use of oxygen increase fluid losses from the lungs. Their thin skin has little protective subcutaneous white fat and is more permeable than the skin of term infants. The large surface area in proportion to body weight and lack of flexion further increase transepidermal water losses. Radiant warmers raise insensible water losses by 40 to 50% compared with loss in an incubator. Heat from phototherapy lights causes even more fluid to be lost through the skin. The ability of the kidneys to concentrate or dilute urine is poor, causing a fragile balance between dehydration and overhydration. Great differences in fluid needs occur, depending on variables such as the infant's size, gestational age, insensible water losses, and medical needs. Normal urinary output is 1 to 3 milliliters per kilogram per hour for preterm infants for the first few days. After 20 hours of life, output less than 0.5 milliliters per kilogram per hour is considered oliguria. Regulation of electrolytes by the kidneys is also a problem. Preterm infants need higher intakes of sodium because the kidneys do not reabsorb it well. If they receive too much sodium, however, they may be unable to increase sodium excretion adequately and are susceptible to sodium and water overload. Assessment. The nurse should be alert for fluid overload or deficit. Monitoring intake and output of fluids helps determine fluid balance. The infant's intake and output by all routes are carefully calculated. Parenteral fluids, feeding tube intake, medication, and oral fluids are included when measuring intake. Output from regurgitation, drainage tubes, stools, and urine should be measured. The nurse should also keep track of the amount of blood taken for laboratory tests because the loss can be substantial and the infant cannot make new blood fast enough. Urine output. There are several methods of measuring urine output. Plastic bags that adhere to the perineum are not suitable for the preterm infant because they may damage the fragile skin. Weighing diapers is less harmful to the infant. The weight of dry diapers is subtracted from the weight of wet diapers to determine the amount of urine excreted. 1 gram is equivalent to 1 milliliter of urine. However, humidification may add moisture to the diaper, and a radiant warmer may cause evaporation of urine on the diaper. When precise measurement is essential, diapers can be fastened instead of being placed open under the infant. Specific gravity should be checked to determine whether urine is more concentrated or dilute than expected. Urine is collected by placing gauze or a cotton ball at the perineum. The specific gravity should range between 1.005 and 1.012. Weight. Changes in the infant's weight can give an indication of fluid gain or loss, especially if the changes are sudden or greater than would be expected. The undressed infant should be weighed at the same time each day with the same scale. Very small infants are often placed in a bed with a scale, so they are not disturbed for daily weighing. They may be weighed 2 to 3 times a day to monitor their fluid status more closely. Signs of dehydration or overhydration. The nurse should observe for signs that indicate the infant has received too little or too much fluid. See the Critical to Remember box for a list of these signs. Critical to remember, signs of fluid imbalance in the newborn. Dehydration. Urine output less than 1 milliliter per kilogram per hour. Urine specific gravity greater than 1.012. Weight loss greater than expected. Dry skin and mucous membranes. Sunken anterior fontanelle. Poor tissue turgor. Blood, elevated sodium, protein, and hematocrit levels. Hypotension. Overhydration. Urine output greater than 3 milliliters per kilogram per hour. Urine specific gravity less than 1.005. Edema. Weight gain greater than expected. Bulging fontanelles. Blood, decreased sodium, protein, and hematocrit levels. Moist breathing sounds. Difficulty breathing. Nursing interventions. Intravenous fluids should be carefully regulated using infusion control devices that administer fluid with a precision of 0.01 milliliters per hour to prevent fluid volume overload. IV medications should be diluted in as little fluid as is consistent with safe administration of the drug and should be considered when intake is measured. Starting IV lines on infants can be a difficult procedure. Once IV access is achieved, care should be taken to prevent infiltration. IV sites should be assessed at least every hour for signs of infiltration. Some solutions, if they infiltrate, cause extensive damage as a result of tissue sloughing. When identified, IV infiltrations require immediate intervention. Many infants have central venous catheters or umbilical lines that should be assessed for infection and possible changes. Small blood transfusions may be necessary to replace blood drawn for frequent laboratory tests. Problems with the skin. Preterm infants have fragile, permeable, easily damaged skin. They often have endotracheal tubes, IV lines, electrodes, and other equipment that should be maintained in place, but standard adhesive tape should not be used because it can be very damaging to the skin. Removal of adhesive tape may strip the epidermal layer of the skin, causing pain and increasing transepidermal water loss and the risk for infection. Preparations used to disinfect the skin before invasive procedures can injure fragile skin and may be absorbed. Diaper dermatitis or diaper rash is common in infants. Assessment. The nurse should frequently assess the condition of the infant's skin and record any changes using a valid and reliable tool. The infant's response to products used for cleansing and disinfection should be noted. Nursing interventions. Guidelines for evidence-based practice in care of the neonate skin have been developed by the AHWAN. Medical adhesives that effectively secure devices and monitoring equipment but cause the least injury to tissues should be used. Skin can be protected from adhesives by using silicone-based protective films. Adhesives should be removed slowly and gently by pulling horizontally parallel to the skin. The interface between the adhesive and the skin should be wet with gauze or saline plagettes. Mineral oil, petroleum, or silicone-based adhesive removers also can be used to wet the area. All disinfectants have potential risks when used on neonates. Aqueous chlorhexidine gluconate solutions are commonly used at this time. Povidone iodine may injure the skin and may have toxic effects on the thyroid gland in premature infants. All disinfectants should be removed with sterile water or saline. Alcohol should not be used. Cleansers with a pH of 5.5 to 7 may be used for bathing infants. Preterm infants usually should not be bathed every day. Warm water without soap should be used for infants younger than 32 weeks of gestational age for the first week after birth. Sterile water is not necessary unless there are concerns about the safety of tap water or there is a break in skin integrity. Stable preterm infants without umbilical IV lines may be immersed in water that covers the shoulders for bathing if there are no contraindications. Swaddled bathing in which the infant is wrapped in a blanket and then immersed in water for bathing, also may be used. Tubs should be used by only one infant for the duration of hospital stay or cleaned well if used between infants. Humidity in incubators should be regulated to reduce the drying effects of heat. Emollients can help reduce fissures in dry skin and transepidermal water loss. They are safe to use under radiant warmers and during phototherapy. The infant's skin should be observed for signs of infection. Infants and their equipment should be positioned to avoid undue pressure on the skin. The most common cause of pressure-related injuries in neonates is from equipment. Skin breakdown may occur over any bony prominence, but especially on the head, which has the largest body surface area. Frequent position changes are important, but should be based on the infant's ability to tolerate changes. Alcohol-free skin protectant and pressure-reducing devices may help prevent skin breakdown. Problems with infection. The incidence of infection in preterm infants is 3 to 10 times greater than that in full-term newborns. Many preterm infants have one or more episodes of sepsis during their hospital stay. Factors that contribute to the high rate of infection include exposure to maternal infection, lack of adequate passive immunity from the transfer of immunoglobulin G, IgG, from the mother during the third trimester, and immature response to infection. Preterm infants are often exposed to situations that may cause infection. A prolonged stay in the hospital increases the likelihood of acquiring an infection from multiple exposures to organisms. Infants are subject to invasive procedures such as insertion of IV lines and drawing of blood specimens. Peripherally inserted central catheters, PICCs, are commonly used for IV therapy. However, catheter-related bloodstream infections may occur and special care is necessary when they are used. Infants often have central IV catheters that require sterile dressings. All dressing changes should be done under strict sterile technique. Assessment. The nurse should be alert for signs of sepsis at all times. See Chapter 24. Nursing interventions. Hand washing is one of the most important aspects of preventing hospital-acquired infections. Nursing care involves scrupulous cleanliness and maintenance of the infant's skin integrity. Even normal flora on the hands of caregivers may cause sepsis. Therefore, parents and staff members should thoroughly wash their hands and arms before handling infants. No jewelry is worn in many units because of the possibility of it carrying organisms. Exposure to family and staff members who have contagious diseases should be prevented. Early signs of infections should be identified and reported so treatment may begin immediately. The nurse carefully notes the infant's response to treatment, because some organisms become resistant to antibiotics. Other nursing care for infection is discussed in Chapter 24. Problems with pain. Infants in the Nicu undergo many painful procedures and treatments such as intubation, heel sticks, chest tube placement, venipuncture, and suctioning each day. Younger and sicker infants tend to need more interventions and suffer more pain-producing procedures compared with older, less ill infants. It was once thought that newborns, particularly preterm infants, were neurologically too immature to feel pain. It is now recognized that preterm infants do feel pain and that painful stimuli cause physiologic and behavioral changes in infants. Pain can have numerous untoward effects. For example, increases in intracranial pressure resulting from pain elevate the risk for intraventricular hemorrhage. Other risks include hypoxia, changes in metabolic rate, and adverse effects on growth and wound healing. Stress and pain in the newborn may alter pain thresholds and cause permanent changes in neural pathways. Tissue injury occurring early in development may lead to a higher sensitivity to pain at the involved site and the surrounding areas. The long-term effects of pain in the neonate are not yet fully understood. It is possible that repeated painful events may cause emotional, behavioral, and learning disabilities. The American Academy of Pediatrics, AAP, the American College of Obstetricians and Gynecologists, ACOG, and the National Association of Neonatal Nurses, NAN, recommend that pain be routinely assessed, painful procedures be minimized, and non-pharmacologic and pharmacologic therapies be used to prevent pain for minor procedures and eliminate pain from surgeries and major procedures in neonates. Assessment. Because pain is the fifth vital sign, pain assessment is performed whenever vital signs are taken. In addition, the nurse should assess the infant's response to potentially painful stimuli and pharmacologic and non-pharmacologic interventions. Assessment tools are available to evaluate physiologic and behavioral responses to pain in term and preterm infants. Some, such as the Premature Infant Pain Profile, PIP, are designed for term or preterm infants. This tool assesses gestational age and behavior states, heart rate, oxygen saturation, brow bulge, eye squeeze, and nasolabial furrow lines from the edge of the nostrils to beyond the corners of the mouth to assign a pain score. Critical to remember common signs of pain in infants: increased or decreased heart and respiratory rates, apnea, increased blood pressure, decreased oxygen saturation, color changes, red, dusky, pale, high-pitched, intense, harsh cry, whimpering, moaning, cry face, eyes squeezed shut, mouth open, grimacing, furrowing or bulging of the brow, tense, rigid muscles or flaccid muscle tone, rigidity or flailing of extremities, sleep-wake pattern changes. Both physiologic and behavioral responses to pain occur. However, physiologic changes may be unpredictable and cannot be used alone to assess pain. Infants who are intubated or too weak to cry have a cry face, a facial expression of crying without the sound of cry. Fewer than half of preterm infants experiencing painful stimuli respond with crying. Infants who have been exposed to prolonged or repeated pain may no longer be able to show behavioral changes even though they are experiencing pain. Critically ill or very immature infants also may not show pain responses in the same way that older, less sick infants do. Therefore, a lack of response to a painful situation should not be perceived as absence of pain. Parents often spend many hours with their preterm infants in the Nicu setting. The nurse should involve them in assessing the infant's pain and encourage them to share their evaluation of the infant's response to relief measures. They may have questions the nurse can answer about the effects of pain and the measures used to treat it. Nursing interventions. Nurses should prepare infants for potentially painful procedures by waking them slowly and gently and using containment. Containment simulates the enclosed space of the uterus, prevents excessive and disorganized motor activity, and is comforting to infants. It involves keeping the extremities in a flexed position with swaddling, with positioning devices, or with the nurse's hands. The infant is in the supine or side-lying position with at least one of the infant's hands near the mouth for sucking. Containment is also called facilitated tucking. KC and breastfeeding also are used to reduce pain. They are a way for mothers to be involved in helping relieve infant pain. The mother's voice and smell, which are familiar to the infant, are added to skin contact to increase pain relief. Handling before a painful procedure should be minimized if possible. Even positioning for procedures can be uncomfortable and upsetting. Therefore, other care should be performed at another time to allow the infant to rest before and after the procedure. If several things must be done together, the least traumatic should be performed first. The infant is often hypersensitive after a painful stimulus and may perceive other activities as painful. Comfort measures help the infant cope with short-term mild pain and reduce agitation. Non-nutritive sucking with a pacifier or the infant's hands is helpful, but is effective only as long as the infant continues to suck. Sucrose placed on a pacifier or in the infant's mouth 2 to 3 minutes before a painful stimulus increases pain relief. Combining sucrose with non-nutritive sucking has been found to reduce pain in neonates when used before and during painful procedures. Sucrose may not be appropriate, however, for very young preterm infants. Talking softly, holding, rocking, and restraining the extremities to prevent flailing are other common methods of pain relief that may be used alone or with sucrose. Measures should be adapted according to the infant's responses. A combination of measures such as skin-to-skin contact and breastfeeding may increase effectiveness. Comfort measures alone are not enough for moderate to severe pain. The nurse should discuss the infant's pain with the primary care provider to ensure that medications are available for long-term and more severe pain. Opioids, such as morphine and fentanyl, can be tolerated by preterm infants. Non-narcotic analgesics, such as acetaminophen, also may be used. Topical anesthesia can be used to reduce pain during some procedures. Sedatives may be used for agitation in sick newborns, but are not effective for pain and should not be used in place of analgesics. Regional or general anesthesia is given during surgery. The nurse gives ordered medications before painful procedures and when indicated by pain assessments. The infant's response is carefully noted to determine the need to increase or decrease the dosage. Analgesics may be given continuously or on an as-needed basis. To be most effective, analgesics should be given before pain reaches its peak. To avoid inconsistent pain relief occurring with as-needed PRN dosing, pain medications are best given on a regular schedule or by continuous infusion. Application of the nursing process. Environmentally caused stress. Preterm infants commonly have difficulty with stress from the Nicu environment. Their parents may have difficulty with bonding. The effects of environmental factors on the preterm infant have led to developmentally supportive care. Developmental care keeps stressors in the environment to a minimum based on the infant's physiologic and behavioral responses. In the past, the effects of exposing preterm infants to bright lights and a noisy environment were not well understood. Improvements have occurred, but noise continues to be a problem. Although the recommended noise level in NICUs is below 45 decibels, levels may range between 38 and 90 decibels or higher. Noise tends to be loudest during report and caregiver rounds and in areas where staff congregate, such as entrances, sinks, and computer areas. The sound of ventilators, incubators, doors, people, and alarms from equipment and monitors can create a noise level that increases the risk for hearing loss and other complications. In addition, stimulation of any kind can cause increased energy expenditure by the preterm infant. Noise and even routine handling and nursing interventions are often accompanied by changes in heart rate, oxygen saturation levels, and behavior states. Preterm infants undergo multiple assessments, procedures, and treatments that may cause frequent interruptions of sleep and may interfere with the development of normal sleep-wake cycles. Sleep disruption alters neuronal maturation and secretion of growth hormone and interferes with growth and development. Energy that must be directed toward coping with an overstimulating and stressful environment may be unavailable for normal growth and development. Although touch is generally thought to be comforting to infants, it is often associated with painful events for preterm infants. This can cause them to develop touch aversion, a negative response to touch of any kind. They may cry, squirm, and recoil when touched, expecting that touch will lead to pain. Assessment. Assess the amount of noise to which the infant is exposed. Determine how often interruptions occur and how the infant responds to different types of care. Assess the infant's ability to tolerate activity and noise. Overstimulation results in changes in oxygenation and behavior. Behavior indications of stress, also called avoidance cues or avoidance behavior, show the infant is seeking to escape the noxious stimuli. Observe for these signs and determine what situations cause them to occur or increase. Identification of patient problems. Preterm infants may have difficulty with multiple stimuli and have a potential for infant stress resulting from exposure to environmental overstimulation. Critical to remember, signs of overstimulation in preterm infants. Oxygenation changes, blood pressure, pulse, and respiratory instability, cyanosis, pallor or mottling, flaring nares, decreased oxygen saturation levels, apnea, sneezing, coughing. Behavior changes, stiff extended arms and legs, fisting of the hands or splaying, spreading wide apart of the fingers, arching, alert, worried expression, turning away from eye contact, gaze aversion, regurgitation, gagging, hiccuping, yawning, fatigue signs. Planning, expected outcomes. The expected outcomes are that the infant will do the following. Show decreasing signs of overstimulation during routine activity as evidenced by fewer respiratory and behavioral changes during handling and increased periods of relaxed behavior or sleep. 2. Gradually show an ability to withstand more activity before signs of overstimulation occur. Interventions. Interventions are focused on providing developmentally supportive nursing care that meets the preterm's infant ability to tolerate stimulation. Developmental care keeps stressors in the environment to a minimum based on the infant's physiologic and behavioral responses. Scheduling care. Schedule periods of undisturbed rest throughout the day to allow the infant to recover from treatments. Avoid waking the infant during the short, quiet sleep phase. If the infant must be awakened for care, try to do it during an active period of sleep when the infant can be more easily aroused using quiet talking and gentle touch. Arrange routine care to correspond with the infant's awake periods and avoid disturbing rest. Decrease the frequency of taking vital signs and performing other routine care as soon as possible. Even the handling involved in routine sponge bathing may cause stress in small infants. Routine daily baths are unnecessary and should be avoided. Bathing every fourth day does not increase skin flora or pathogen counts. Bathing should be postponed until infants are physiologically stable. Cluster or group care so that several tasks are performed at once to allow for more rest between interruptions. However, keep clustered care short and be alert to the infant's signs of stress. Too many activities may be more than the infant can tolerate without rest. Clustered care may not be appropriate for preterm infants younger than 28 weeks of gestational age. Provide short rest periods or timeout periods for recovery within grouped activities or during long or painful procedures. Do not include painful procedures in a cluster of other care. Rest is needed before and after painful procedures. An important nursing responsibility is managing the infant's care by coordinating activities of different healthcare workers.